Before I start this lecture, I want to ask how many of them do SPECT CT in this room? And how many believe SPECT CT is spectacular? Maybe 40%, but my job is by the end of this talk, I will try to convince that at least 90% should raise hands to say SPECT CT is spectacular. That's my job for the next 1 hour. So again, radiological imaging, it's the same thing. It helps in detection of the metastasis, pathology, and prognosis. But my job is to convince there is a role for MDP bone scan. As you can see, historically, you started with rectilinear scanners, then you went to planar imaging, then we converted to whole body, then SPECT, and in 2004, 2005, we went to hybrid technology, because before that, people used to do what is called as a software fusion by doing a CT in a different machine and bone scan conventionally and try to fuse them. It used to work, but only thing is the problem is you need more staffing and the technology is quite cumbersome. So only the most recent technology in 2006 and 2007, most of the cameras coming out are the hybrid cameras. And in fact, in future, there'll be nothing called as a conventional gamma camera. Every camera will be a hybrid system. Coming to bone scan, as I said, it's a most common screening test. Ability to scan the entire skeleton. Again, this statement is made somewhere in 70s and 80s. Today, any imaging technology can do a whole body scan. It's got high sensitivity, there's no doubt about it. It's available, and it's quite cost effective in terms of the oncological pathway. It lacks specificity, and we often are moved towards the degree of avidity. We always think increased uptake means something sinister, like exactly like a radiologist, marrow change is something, but again, marrow change is non-specific, similar to uptake in a bone scan is again non-specific. And the problem with MDP bone scan is benign pathologies do take a tracer, and therefore you can't give a definitive diagnosis in most cases. Especially if it's a solitary lesion, the chance here is we go into this mode. Some will say metastasis, some will say suspicious, some will say suggestive of benign. And the most intelligent guy will say, I'll do further imaging to get out of the problem. And some people will say, I've got an experience of 20 years, I've seen 20,000 scans, and therefore I know it's metastasis. But one of my teachers used to say, experience is, the definition of experience is doing same mistake with greater confidence. That's the meaning of experience. So coming to SPECT CT, when you want to use it, as a nuclear medicine physician, you will ask me, what is the evidence for me to switch over from planar imaging to hybrid imaging? As a clinician, all I'm interested is I don't care what technology you use, I need accurate localization, a definitive diagnosis. Do anything, but give me an answer. But for the patient, all I need is definitive management, early diagnosis. So can SPECT CT answer all these questions? That's going to be my talk. What we do at Guy's and St. Thomas's Hospital is every patient will have a bone scan, which is a whole body scan, and we look at the whole body bone scan, then we do a whole body guided CT of that particular area. So in this case, if you think some patchy uptake in the spine, if you're not convinced, or if it is equivocal, then you will go for SPECT in this. The CT takes about a minute, and the bone scan, the CT, the SPECT bit takes about 20 minutes approximately, and then you get a fused image for a definitive diagnosis. Next, you'll ask me, what is the evidence? You know, you're showing some pretty pictures. Does pretty pictures has any meaning? Because ultimately, pretty pictures should lead to better prognosis. That's what the clinician will ask, because we are very good in terms of defending and showing our success within nuclear medicine fraternity. The moment we go to radiology, we are half stumped. When we go to oncology, we are fully stumped, because all an oncologist asks is, fantastic, you made a diagnosis, whether it's going to change my patient pathway or the patient outcome. Unless we have a definitive answer towards patient outcome, we are quite good within our branches, but we need to explore our wings beyond nuclear medicine and show that we can add a specific pathway in terms of their diagnostic algorithm or a therapeutic algorithm. This is a paper from 2004 looking at 104 equivocal lesions, and they inferred saying that SPECT CT currently classified 85% indeterminate lesions compared to just 36% with SPECT alone, and significantly improving your specificity and diagnostic accuracy. Another paper in 2010, 140 lesions, and the final diagnosis, they definitely clarified 63 were malignant, 78 were benign, and they said SPECT CT was significantly higher when compared to SPECT alone. All the papers say similar results. 2006, 52 indeterminate lesions, SPECT CT classified 92% of the lesions as definitively malignant or benign, and few lesions, about 8%, were indeterminate in scapula and ribs, which is quite challenging. Even with whatever technology you use a CT or an MRI, definite confirmation of a sinister pathology in ribs is quite challenging even now. And Strobel from Switzerland, again, evaluated 37 patients, 42 lesions, and they inferred, saying that planar scintigraphy suffice to differentiate benign and malignant lesions, but SPECT CT significantly increased the certainty of diagnosis, and that's what you want at the end of the day. End of the day, you want to go home happily saying that I made a definitive diagnosis, rather than passing the buck to the radiologist saying further radiological correlation is suggested. So next few slides we'll have an interactive, and this is a patient with prostate cancer, multiple foci of increased uptake in the spine, and the sternum, and in the pelvis. How many will go for metastasis? You can raise a hand. Only I'm being recorded, so don't worry. Nobody's going to see you. Mets. Okay, benign disease. I don't know. I would have said, because it's most towards the costo-vertebral junction, it's quite tricky, but in this case, all the lesions turned out to be sclerotic, and it was positive on the bone scan. So I could make a definitive diagnosis rather than just on the bone scan. The sternum gives away. There are some two foci. It's definitely going to be metastasis, and the ischium also will have metastasis. But the question in the spine, out of those 10 lesions, how many are benign and how many are metastasis is challenging. So with SPECT CT, you can get a definitive diagnosis. This is a patient, metastatic bladder cancer. There's some uptake in the pelvis. The problem here is it's a lytic lesion. Unless there is a osteoblastic reaction around it, you will miss. And patients with bladder cancer and also patients with lytic bone scan will underestimate the disease process, whereas with a combination of SPECT and CT, you will at least give a more confirmative answer. Malignant or benign. This is a patient with lung cancer. There's uptake at L5. How many will go for malignancy? Good. How many will go for benign? Benign? I don't know. Good. In this case, if you would have called benign, you would have won. If you would have called malignant, you would have been in problem, because that turned out to be just facet joint disease. So you made a definitive diagnosis by SPECT CT rather than saying it is suspicious. Radiological correlation, that's what I would have said if I would have just a bone scan with me. This is a patient, prostate cancer, rising PSA. There is a subtle focal uptake in the spinous process. Benign. How many will go for benign? Malignant. Suspicious for malignancy. Fair enough. If it had said suspicious or metastasis, it would have been definitive. You can see there is a sclerosis in the spinous process. It was a definitive bone metastasis. Therefore, you have changed from equivocal to a definitive diagnosis, and that's what SPECT CT will do. This is a patient with renal cancer, back pain, hip pain. The clinical question was, is the patient has metastasis? You can see there is patchy uptake in the sacrum. And the clinical question was patients having hip pain. And you can see there is some low-grade uptake, which we see often in most of the bone scans. But still, we went on to do SPECT CT in this patient. You can see there is a huge lytic lesion you would have missed with just the bone scan. So combination helped us to detect something which has got a potential, or is definitely going to fracture if you don't organize. Pattern recognition. As imaging specialists, we believe in pattern recognition. 2 patients with cancer, more or less looks similar. How many will go for metastasis on this first one? If this one, bone metastasis or benign? How many will go for benign? How many will go for metastasis? In this case, the first one, there is a big lytic lesion there with a sclerotic margin. That was bone metastasis, and that was just end plate degenerative disease. So you will have a definitive diagnosis from equivocal to definitive benign or malignancy by adding CT component to your SPECT technology. Limitations of planar, especially this is a Friday evening scan. There's a focal uptake somewhere, and you know it's renal, and you know it's bladder. It could be contamination. You may say it's contamination and go home. There's a focal uptake, and I wouldn't have worried too much about it, but we did a SPECT CT, and there was a sclerotic lesion in the pubic symphysis, definitive diagnosis of metastasis. In this case, some people would have picked up based on how cautious they are, but a few in the early stages of bone reporting may have said, okay, anyhow, it's going for urinary contamination, so we could have missed bone metastasis if you don't have an additional hybrid imaging. This is an interesting case. Patient with prostate cancer, increasing pain in the right ischium, planar bone scan. Is there anything abnormal on the planar bone scan? Normal? Anything in the ischium? I would have said it's a normal scan. But on the SPECT imaging, there is a focal uptake, and that turned out to be a sclerotic lesion, bone metastasis, which is also confirmed on the MRI. So planar bone scan will often miss. Whenever the patient is symptomatic, the rule at Guy's and St. Thomas's is we will go for a whole SPECT imaging. We have a general rule at Guy's and Hospital, even if the bone scan is normal, if the patient is symptomatic, that particular area will be SPECTed. But now we have SPECT CT, so often everybody will get a SPECT CT. So any patient with a normal scan who is symptomatic, the standard teaching is the patient should go for a SPECT imaging. Definitive reports is one of the important components. This is again a patient with breast cancer, subtle patchy uptake in the spine. The question was whether the patient's got metastasis or not. With planar imaging, I could have erred towards suspicious, or I would have said inconclusive further imaging, or I would have said just benign disease based on the level of experience and level of confidence. But with combination, there is sclerosis, increased uptake, definitive metastasis. Therefore, you give a definitive answer to the clinician. Why it's definitive? Anyhow, they're going to pick up in further imaging. But the problem is you have a one-stop imaging. So patient comes for a bone scan, you can always do a CT. If you say an equivocal scan, further radiological correlation, at least it takes a month for them to come back to the clinic and ask for a CT and further correlative imaging. Everything changes because we work in a government sector, it's an NHS, there is a huge waiting list. So if you have a one-stop imaging, it really helps to clarify benign and malignant disease. This is a patient with lung cancer. The question is whether that's METS. You will say highly suspicious, but also there is some patchy uptake in the spine. But being a combination, you can see there is a lytic lesion. That is definitely metastasis. And the other thing is turned out to be facet joint disease, which is obvious on the bone scan based on the experience level. So you give a definitive answer in this condition. But the problem is sometimes the SPECT CT technology may not give you all the answers. It is good up to 95%, but sometimes it challenges you. In this case, the bone scan is relatively shows increased uptake, and then it shows increased uptake on the SPECT. I'm more convinced, but on the CT there is hardly much sclerosis there. So the question was either to do a follow-up scan in 3 months' time, or the most intelligent will ask for an MRI. In this case, we asked for an MRI scan, and it turned out to be 2 metastases. That turned out to be metastasis, but again, as you can see, there is some patchy uptake, but you wouldn't have bothered calling it even on a traditional bone scan. But on the MRI, there is another foci of uptake, so therefore you are doing a definitive diagnosis in this group of patients. One of the major problems is most of the publications as of now, it's retrospective. And whenever we submit papers, they ask for a gold standard. The gold standard has to be histology or radiological follow-up or a clinical follow-up at least for 1 or 2 years. But most of the, you can't biopsy every lesion to confirm or refute the disease. And also the challenges is often they talk in terms of additional radiation. But the problem today in the world is as soon as a nuclear medicine physician asks for an extra scan, whole world talks about radiation. But a radiologist does 10 CTs, nobody questions the radiologist. So, and also training is important. Training in cross-sectional imaging is challenging because oncology, I don't think, because we are more used to oncological imaging and more or less we are okay with oncologic imaging. But my next bit of talk was about benign, where it is really challenging even for a conventional radiologist. So overall, what does SPECT CT adds to our general practice? It helps in localization. It helps in accurate characterization. It increases your specificity. It gives definitive diagnosis. And often you will ask for further investigations. At least I'll have an idea which area the other imaging modalities has to concentrate. So in the end, I think SPECT is useful. So how many at the end of my talk feel SPECT CT is useful? Maybe 80%. I'll bring it to 90% with my next talk.